me tell you, for anything that I have done, your story and your bravery and your courage and your success is just, I'm sorry, it just makes my resume pale in comparison. I think you deserve a lot of credit for sharing your story. And I'm so pleased that your story is able to be told and that you are here to tell it. Because what I'm going to talk about is really important to me, because not everybody survives to tell the story. And we want to make sure that we help people to the best extent we can. And that's why there's a lot that's going on with crisis services. And I want to focus a little bit on that. So I'm going to have to be able to share my screen. And so I need the host to enable my screen sharing, if you don't mind.
You should be all set.
Okay, let me try it again. Yeah, there we go. But I also, so what I want to do is talk, what I want to do today is talk about a couple different things. I want to talk about just some of the data that we're seeing in Michigan, across Michigan. I don't have Washtenaw County specific data. I'm sure you've heard that at other parts of the presentation. But then I want to talk a little bit about crisis services. I want to talk about disparities that we have to think about as we're addressing the needs of people who are struggling with opioid use disorder and other substance use disorders. And then I want to talk a little bit about some of the challenges with social determinants of health and social determinants of mental health that can help guide us. And then finally, I want to close with just some thoughts about the importance of engaging people in care and what challenges there are and what opportunities there are when we do well by that task. So you heard a lot about me. I have no conflicts related to this presentation, and any opinions I express are mine and not anybody else's who I'm affiliated with. So let me just start with talking a little bit about the data that we're seeing in Michigan. Unfortunately, we are not seeing good numbers. The opioid overdose death rates are higher. This, in 2021, the year we have the most recent data for, we're still collecting 2022 data, but they're higher than they were in 2019 and 2020. We're seeing that around the country, that during COVID, the numbers have gotten worse. If there is any good news at all, before COVID, we were seeing a little bit dip down in the numbers, which I hold on to when I get overwhelmed at times. And I think, our strategies were starting to trend us in the right direction. And then COVID really did create new barriers and obstacles and maybe some opportunities to further dial down and do better. We're also seeing a lot of overdose emergency department visits. Those have gone up steadily as well, the number of non-fatal overdose visits. And on the one hand, you can say, maybe that's really good data because people are not dying and coming into the emergency department and able to be rescued, which is great. If it wasn't correlated with the higher death rates that we're also seeing, I would look at this as a potentially optimistic figure. On the other hand, do we want this many people coming into the emergency room with non-fatal overdose rates? No, we don't. And, it's lower than it was in 2019, but again, it trended up after the 2020 period. So we'll have to see what that looks like. So when I think about crisis services and the way the direction we're going is in society now is really trying to look at crisis services beyond just the 911 response that would typically happen with an opioid overdose. We really want to think about crisis response upstream and then during the crisis and getting the right response to the right people at the right time. So Michigan has some pretty cool things happening with crisis response. We initiated MyCal about 1.5 years ago. It's due to be rolled out across the state, if it's not quite already, by the end of this year. That's the Michigan Crisis and Access Line, a single number that anyone in Michigan can call for supports. And then on top of that, federally, 988 was passed in 2020 as a 3-digit number to access have for the Suicide Prevention Lifeline, the National Suicide Prevention Lifeline. And with 988 going into effect on July 16th, 2022, the idea was also that it would be more than just a suicide prevention lifeline, that it would be a crisis line. And the idea behind that is that the individual defines the crisis, and that the hope is that we get ahead of the moment when somebody is so suicidal that it's really difficult to rescue them. And that people can call and access a number of someone to talk to, someone to text, someone to chat with. We have all sorts of features related to that. And this will all be tied in with MyCal. So again, we were starting the trend. We're sort of ahead in terms of getting that network of answering spot centers available with that 988 number. And that means a lot for people with opioid use disorder. And I think, like Kayla's story points out, there's often this co-occurrence that's happening where people may be having some depression, anxiety, trauma-related symptoms, as well as substance use disorder. And we don't want people to have to sort out whether they qualify or don't qualify to call. This number is available for people with substance use related crisis or in a quote mental health related crisis. We saw that in 2020, the volume across the United States of people calling the National Suicide Prevention Lifeline was really high. And again, you want to think that is fantastic that people are using it. Over 1.8 million people called to over 180 centers. Then we have there was a separate veterans crisis line, and then there was the disaster distress helpline, and that really took off when COVID first emerged. So it's great that people are calling. It's, obviously a societal concern that we have so many people that need these numbers, but we do, and we need to make them available because the data shows that they do help and they can save a life. There is a lot of kind of negative blog posting going on right now about police intervention and forced interventions and things like that. We really want to get ahead of that conversation to understand that there are many, many things that we are learning, protocols that are being developed, and that most calls are resolved from a conversation. Most calls do not involve sending somebody out. And even when someone is sent out, most of the time, by far, the person wants that person sent out after a conversation with the right kind of trained call responder. And what we see from the data, which is pretty great that we were able to have data on this, and I know more data is going to be collected, but suicidal crisis callers report significant reductions in intent to die, hopelessness, and psychological pain over the course of the crisis calls. Sometimes just having someone to talk to can really help. Callers in crisis collaborate with call centers on interventions on over 75% of the imminent risk calls. That's what I mean. Even though the blog posts are talking about forced interventions, in over 75% of the calls where there was an intervention that was needed, this was a collaborative intervention. It was not a forced upon somebody who didn't want it kind of intervention. And that emergency services are only going to be deployed in about half of the other calls. Again, we can really de-escalate situations through phone calls and help people get to care. Also, crisis chat services are found to be much more user-friendly for younger populations. People sometimes feel more open in a crisis chat. So we do see more suicidal ideation expressed in a chat even than verbally. And yet we know that there's a lot more that needs to be done. This was an expose by Pew Charitable Trust that showed that call centers around the country didn't really have what it takes to have the call center have the behavioral health crisis training. There were limited options, and there was a need for additional resources. One of the things that excited me about doing the keynote today is I know in Washtenaw County, as a now former resident, because now I'm in Oakland County, of Washtenaw County, the Washtenaw County resources are amazing. And the call centers, you've got a lot going on with Sheriff Clayton and Trish Cortez really working hard to collaborate around how to address the needs of the Washtenaw County population. There are many opportunities still for improved outcomes. There's lots of things to think about as we roll out crisis services. We want to really make sure that we use the least invasive approaches that will help people get to that recovery stage as much as possible. We really want to be building out services that help people get to yes without forcing that yes. And so that means that we have to really think about how the laws and authorities work together, what the Good Samaritan laws mean, and then just regulatory spaces and places that may not be of interest to some of you, but are important to us, that are rolling out policies to try and meet the needs of populations. There has been this trend, and of course, the murder of George Floyd made things very complicated in a way. It was, obviously it was a very, very tragic situation. It did lead to a big cry for defunding police. But what I think people have stepped back and realized is that we really have to make sure that we don't just have our first responders walk away, but instead lean in when that's necessary, but lean in with the best tools available. In this one report by the Treatment Advocacy Center focused on people with mental illness, it was seen that law enforcement and fatal law enforcement encounters with people were disproportionately impacting people with mental illness, and other studies have shown disproportionate impact of people with mental illness and Black and brown populations. Now, what this means for people with substance use disorder, I'm not exactly sure, but having studied this data for many years, we do know that there are high chances of use of force in situations where people are intoxicated. That could be because the individuals may be more dysregulated themselves, but it also tells us that we need to do a lot more related to partnerships and training. This is a paper that's freely available to the public that you all can read, that I helped write, about law enforcement and crisis services and how we can learn past lessons for new partnerships. And I'll talk a little bit more about that today. This other study from 2018 showed that with fatal law enforcement encounters, again, 23% of individuals displayed signs of mental illness. Now, some of those individuals could have also had a substance use on board. And in fact, in my work with looking at many, many cases across the years, very often there is a comorbid substance use and mental health condition in these types of encounters. And again, race and mental illness were strongly correlated for these negative outcomes, as well as people brandishing weapons and things happening in home environments. So we have a lot more to learn about how to work with different populations and people in different states of mind and capabilities. And one of the places where I really draw from history is my colleague, Matthew Edwards, is a historian. He's a psychiatrist historian, and he studies issues related to race and equity. And he's really taken on this history of the Freedom House Ambulance Service, which I think is a really cool story. It started in the 1960s and 1970s, and it was what was called a community-based socio-medical program. And it aspired to encourage Black enterprise, but also it was to address the needs of populations where people were reluctant to come into healthcare, and communities were reluctant to go, and providers were reluctant to go into communities. So the idea was that there would be a Black-run paramedic service. This was in Pittsburgh, Pennsylvania. And actually this particular service set the standards for EMS training and delivery that are still with us to this day. They helped replace police, firefighters, and morticians who were otherwise going to the scene for medical emergencies. So you had people, law enforcement, firefighters, and morticians even, that were being called into Black communities to help deal with medical emergencies, and they were ill-equipped to do so. So this Black-run paramedic service provided that. It became a national model for public health systems, and then it improved all sorts of ways of delivering high-quality service. And it helped address the needs of highly visible members of marginalized populations. However, sadly, what happened with the Freedom House Ambulance Service was that it eventually ended, partly because this big corporate super ambulance kind of services and the monetization of ambulance services at the time in Pittsburgh kind of came about, and more was being learned about EMS. And so this little program was replaced by bigger services. I think even though it was sad for many to see that go, there are important lessons to be drawn from it in terms of looking at how do we help work with law enforcement so that we avoid these overzealous, quote, preventive approaches to policing but then also don't have underwhelming responses that leave communities with high social determinants to struggle. So getting that balance of the right policing at the right time is going to be really important, and also helping give the police the tools that they need, as well as the community mental health services that are going to be going out to these crises so they can work together in partnership and deal with populations equitably. So really where I've been spending a lot of time, and actually a lot of my thinking has been shaped from some of the work with Sheriff Clayton and Trish Cortez at CMH, is really thinking about shared understanding of the various populations and their needs for crisis services of tomorrow. And part of why I want to point this out is because our data on opioid overdose does show that we have major disparities as we look at overdose rates. So ED visits and overdose rates, you can see Hispanic, Black communities just largely impacted in ways beyond what white populations. And here's the overdose death rates by quarter across race and ethnicity, with Black populations far exceeding other populations. We also know that right now overdose deaths are really complicated when we look at what's in people's systems at the time of death. We look at the number of samples that test positive for fentanyl, and really it's kind of like fentanyl is with everything. And so that's kind of the message here, is that we're seeing fentanyl in most things. We also know that there have been other examples of disparities. We certainly saw disparities in COVID-19. Interestingly, in the 1918 flu pandemic, there were also racial disparities that were seen. So we see disparities in all sorts of angles that we have to think about. And so how do we attend to the needs of diverse populations in crisis behavioral health services? One is really understanding who those populations are and how do we uniquely meet their needs. For example, the needs of particular racial and ethnic groups, immigrant needs, non-English speakers, the LGBTQ+ community, children and adolescents, older adults, people with intellectual and developmental disabilities, and the medically complex populations, and then the intersectionality of those issues that may confound some of the positive outcomes that we're seeking. And so we know that there's been historic and current barriers to access services. We know that there's been challenges in diagnostic issues. We know that people with substance use disorders of certain racial and ethnic populations are going to be triaged more likely to the criminal system. For example, it's 13 times more likely that Black men will be triaged to the criminal system. Black youth will be 2.5 times more likely to be diagnosed with conduct disorder than adjustment disorder and attention deficit disorder. We know that there's barriers to access care, and that individuals, Black and Brown communities, may be less likely to want to use professional mental health services, especially if they don't feel that those services are meeting their needs. And also there's just a legacy of abuse and exploitation that contributes to distrust in the healthcare system on top of this historical trauma. So we really have to think about the role of cultural differences, stigma, religion, coping styles, trauma, and familial influences and sense of trust in the system overall to help build out services that meet the needs of populations. And this is just data that really furthers this in the opioid conversation, just looking at these disparities. And so how do we bring in culturally sensitive groups to help reduce the needs of to help meet the needs of the populations that we're trying to serve in Washtenaw County and elsewhere? The other thing to think about is that we are in this movement of shifting, just like if you're having a heart attack and EMS goes out to revive you, we've learned a lot about CPR. If you're having a stroke, we've learned a lot about how to get you medications as soon as possible to improve your chances of survival, even out of hospital, before you can be transferred to a medically appropriate setting. And so this idea of out of hospital care, I think, translates very well to what we're trying to do with behavioral health. If somebody is having a behavioral health crisis, whether that's a substance use crisis or a mental health crisis, we're going to get better and better at out of hospital care, just like with CPR. For example, we already have EMS using naloxone. That's been longstanding, but police are now have naloxone available. That was a big change. I remember when that first started, there were a lot of people that were worried about that. How would a layperson administer a medication? That seems like that we should wait for EMS. But if the police weren't doing it right away, then you would end up with overdose deaths. And so we're learning a lot about out-of-hospital care. There's lots of discussion about, for example, for somebody who's ready, willing, and able to engage in their recovery, trying to induce buprenorphine in the field and help people get to their recovery sooner so that they don't have to go through even more painful withdrawal. And so I think we're going to learn a lot about that, especially as new models are developed around specialized responses that partner with police and either go out by themselves or go out with police in the same car or meet police on the scene when that's necessary. And so there's a lot of models that we're seeing around the country for multidisciplinary responses. In high-risk situations, there's going to be times where police are going to be necessary. And so how do we help support police so that they can have the best outcomes possible? This is an example I'm pretty proud of. This was a Washtenaw County example where you may remember a March and a half ago, 2021, there was in Washtenaw County a barricaded gunman who had surrendered peacefully after a 36-hour standoff. For random reasons, and I was still a Washtenaw County resident at the time, I was called to help at the scene. The CMH was already very involved. And through the interventions of the partnership and through the very brave conditions of the law enforcement responders who were numerous across that 36-hour period, there was a watch and wait kind of attitude to allow this individual to move himself towards turning himself in, which eventually he did, and no one was injured. In another neighboring county around the exact same time, there had been an officer involved death that occurred, which was, pretty tragic. So it was pretty positive that Washtenaw County was able to yield a positive response. And I would say that was there was a lot of work that went on from the top down, the sheriff's office really helping train their staff appropriately, as well as bringing in partnerships with behavioral health to help reduce the likelihood of a negative outcome. So it is possible, seen it, and really hoping for more of those as we go forward. Also, what do we need to think about for LGBTQ youth and specific crisis issues? This was a study that was looking at how often do LGBTQ youth want to access a crisis line. There's this definite data that shows that having a specific crisis line where the call responder is LGBT affirming, and really can help that person through that crisis. So we're trying to work with our crisis lines to help address the needs of particular populations. So the important thing in crisis services going forward is really being trauma informed, looking at the needs of specific populations, figuring out how to engage with peers who can really meet people where they're at and build those partnerships at the ready and on call. This will also require understanding of social determinants of health. So I know I'm pivoting and I'm going to switch gears, but I think this is an important kind of underlying challenge that we have. What are social determinants of health? They encompass the conditions in which people are born, grow, work, live, and age, the wider set of forces and systems shaping the conditions of daily life, and are mostly responsible for health inequities, which are the unfair and avoidable differences in health status seen within and between countries. And some of this comes from early studies. For example, the Whitehall study, the first one began in 1967 out of England, and they looked at mortality rates amongst adult men, and they found that there was an inverse relationship between the level of employment and mortality. Lower grade employment led to higher mortality. Messengers, doorkeepers had a 3 times higher mortality compared to administrators. Some relation to this was related to other health habits, smoking, obesity, less leisure time, more stress to make a living, less physical activity, and higher blood pressure, baseline illnesses may have also contributed, but it was hard to know chicken and egg, which came first. And so even pulling out these other factors, the lowest job grades had higher mortality compared to higher job grades. There was a second version of the study that was conducted as a follow-up, and again found some of the same things, that that heart disease, ischemia, continued to be seen based on employment category, and poor health conditions, smoking, weight, level of physical activity were common with people with lower job statuses. So that's not to be elitist. It's something to think about in terms of what it tells us. And that really what we have to understand is the upstream lack of economic opportunity can lead to downstream poor living conditions and influence health in a negative way. And so we have to think about considerations of social determinants of health. And now people have drilled down even further to talk about social determinants of mental health. So these are the basic domains of social determinants of health that you see that have been promulgated. And I'll just take each one in turn just to have you think about it. First is healthcare access and quality. Are people able to access care that is comprehensive and high quality? 1 in 10 people still in the United States do not have health insurance and may not be able to afford medical care or medications. And preventive care is often not a covered service. Now in Michigan, we have Healthy Michigan. We have many more people that are able to access insurance. The question is, can they access the care that they need? And people with substance use disorders often have difficulties due to stigma and other factors or availability of services. They have difficulty accessing that health care, which is going to be so critical. And if there's stigma against people with substance use disorders who might come in with chest pain or heart conditions, and they're not treated fairly within a regular healthcare setting, they're going to have difficulty accessing the care that they need. Education and access quality similarly linked to greater health and longer lifespan. Education is a key variable in how people do. And so we have to really think about poorly performing schools, lack of means to attend college, poverty that impacts brain development, and all that can impact educational attainment. The social and community context also matters. Unsafe neighborhoods, discrimination, social isolation, all can negatively impact health. Children and adults alike need connections and social supports to do well. Economic stability. 1 in 10 people live in poverty across the United States. And even in Washtenaw County, which tends to have some means, we have major areas of poverty where people are having a hard time making ends meet. And people with steady employment are less likely to live in poverty, yet we know that there's been very unsteady employment. And we certainly know that people with substance use disorders have unsteady employment. And so that creates a whole other host of health hazards. Also, neighborhood and built environment. Neighborhoods with high rates of violence, unsafe air or water contribute to health risks. I mean, we know what happened in Flint. Persons of racial and ethnic minorities with low incomes are more likely to live in these types of neighborhoods. So we really have to think about that. I really love this picture that really depicts what this is about. You can take the same 2 fish and put them, one in dirty water and one in clean water. Would fish 1 be as happy, safe, and healthy if its water were dirty? What if its bowl were cracked and water was even leaking out? And then you could look at fish 2's perspective. No matter how much fish 2 tries, even with the best genetic loading, it may never reach its full health potential due to its dirty water and its cracked bowl. And this is one of the things we have to think about as we're addressing social determinants. The social determinants of mental health go on and really look at what is it that are X factors outside of that individual's genetic makeup that could contribute to mental health and mental positive health and mental and poor mental health. Unemployment or precarious employment can be linked to psychological distress. Okay, think of our population of people with opioid use disorder. Public health care, work strain and mental health, financial strain that can lead to mental health challenges. We know that lower income is linked to suicide attempts and depression. Poor mental health is linked to poor quality housing, food insecurity, discrimination, which can include social ostracism, negative familial relationships, which we just heard a personal story about, what can happen for people with opioid use disorder or substance use disorder more broadly, that can really put that strain on somebody's mental health, which then digs this hole and makes it much harder for people to then come out of and get on top of. So we really have to consider what this means for an individual with opioid use disorder. What choices are really available to them? If they're having family discord, which is a totally common scenario, then what are the alternatives that are available? Peer support, of course, comes to mind as one option. If they're not in stable housing, what choices do they really have to find stability? So choices we make depend not only on the choices we are making, but the choices that are available to us. And in many instances, there is a narrowing of options that are available to people, which leads to more and more negative choices. Now, for people that are court involved, which a lot of times we see with substance use disorders, what does this mean in terms of how is the court looking at these options? A court may look at, well, you just didn't show up, so you're going to be violated on your probation. But they may not understand that the person had no transportation, they had just had a baby, they were taking care of a sick older adult relative, thousands of reasons that could go on and on why somebody doesn't show up for an appointment that could relate to all of these factors. So how do we help when somebody is criminal legal involved to make sure that people are aware of what the circumstances were around why there may have been a failure to meet the terms that were necessary? Now, I know some courts, like there's models like Hope Moore, that really don't look at kind of reasons for non-compliance. They say non-compliance is non-compliance, and if we can just give you swift and certain sanctions, we can be more equitably distributing how we mete out justice. And I think there's a balance between those two models that need to be considered. It's very important that communities, and I would suggest Washtenaw community probably has already done this, but look at their health impact, look at all of the policies and practices around what is happening in terms of health impact. Are there policies and practices in how services are delivered that really don't set people up for success? And this is why I want to talk and end on this note about engagement. How do we set people up for success? How do we set people up for success when they have become addicted to a variety of substances and where their brain is more triggered by cravings and avoidance of negative sequelae and concerns about trauma re-exposure? How do we engage somebody that's got all of these pulls towards ongoing use, just tremendous pulls towards ongoing use, social support system, all using that peer feeling like you belong? There's lots of data that shows if you're socially isolated, that can be one of the cruelest forms of punishment. Anyone that's been ghosted and knows how hard that is emotionally understands that ostracism is we are social beings. Our brains are wired to be networked together. Hopefully more for the good than for the bad, but there are networks of humans that work together, and that's just how our brains are wired. So if you ostracize somebody, which was in the olden days, the term ostracism came from a form of punishment for people. If you socially ostracize people, they're going to really suffer. And so how do we make sure that so if somebody is drawn to a negative peer group, it may be because they don't have an alternative peer group to be drawn to, and yet they need a peer group. So how do we as providers and as a community build in engagement strategies through communities like this one and this summit that you're having today, so that people who are trying to strive for recovery, or who may be just a toe in the water ready to think about trying to engage in recovery, have a warm, friendly community to greet them and bring them in? Well, one way is we have to really recognize the role of trauma. Early childhood experiences can really set a trajectory towards social, emotional, and cognitive impairment, adoption of health risk behaviors, and all sorts of downstream consequences like disease, disability, social problems, and early death. This comes straight out of the CDC and lots of studies on adverse childhood experiences. Adult trauma similarly, and very often we see that people who have faced adult trauma have adverse childhood experiences on top of that. For example, some of the people that we've seen in veterans treatment courts, they may have combat exposure as an adult, but the ones that fare particularly have particular difficulties may also have trauma prior to the age of 18. So it's kind of that pile-on effect. And so one of the things for engagement that we have to do is recognize the role of trauma and think about strategies to be trauma informed and really think about referring people to trauma-specific services. Engagement is really difficult because it gets to be cyclical. You have people with complex conditions and trauma histories where they may not have a lot of trust. They've been burned before. They may not have had early attachments because they may not have grown up in a rich and nurturing environment like our fish in the broken fish tank. And then because of these complex conditions, they may be highly likely to drop out of care. They might go to the emergency department to receive their care. Staff who are trying to engage them in the community are just incredibly burnt out. They say, you've burnt every bridge. We've tried this before. I can't work with you anymore. It's very difficult to stay engaged. And so engagement strategies become complicated, which only furthers the complexity of the condition is that we are trying to support. So we have to be really intentional about how we engage people in services and how we communicate to people how much they matter to us and how working with them is worth the time and how their working with us is worth their time. So it's really about fostering cultures of engagement across systems. When there is a crisis, what is the follow-up? How do we prioritize engagement in and of itself? Meaningful peer and family involvement, collaborative opportunities, helping meet people where they're at instead of railroading them into something that's never going to be what they want anyway. And then looking at data on barriers. What is making it difficult for this person to stay on medication for opioid use disorder? Are there triggers or stressors that come up that each time get them to go kind of off the rail and into some poor decision-making when they really want to be in recovery, but things are happening? For example, we know if people are struggling still with cravings, despite best of intentions, those cravings are going to draw people further. So are they on medications, for example, that can help reduce cravings? And what kind of therapeutic supports are they getting to help reduce those cravings and develop some strategies to address the cravings when they do come? We know from the Center for Behavioral Health and Justice data from 2009 that engagement across systems is just as important as engagement. That if you have connections, for example, this is a complicated slide, but what it shows is if where there's connections from community mental health into the jail, which again, Washtenaw County leads the charge here, because in Washtenaw County, you have CMH providing those behavioral health services. And so you're going to have people with a relationship already with opportunities for connections to the community. But that shows very much people with those relationships inside the walls are more likely to engage in treatment post-release, which is so critical. Other aspects of engagement are really looking at, how are these relationships? How can we look at disruptive engagements and see what went wrong? What did we do as a system or as a community that didn't support this individual's success? Instead of calling this person treatment resistant and blaming the person who's trying to get into recovery, we have to look at as a community and as a system, what is it that we're not doing that's meeting their needs? How much are we looking at the attitudes and interpersonal skills of caseworkers? Because it's really not about just getting the paperwork done and meeting the Medicaid requirements for billing for case management. I mean, obviously that's work that has to be done, but nobody went into this business of supporting people in recovery just because they wanted to fill out paperwork. People went into this because they really wanted to meet people where they're at and help them. And so it is really about listening, understanding, again, helping people with reminders, removing barriers, building a relationship and a rapport, helping them make better decisions for themselves, and really humanizing some of these more official roles. So I would say that there are many factors that can influence an individual's recovery and their ability to stay healthy and well-being. We also know that as crisis services roll out, they're going to look very different. We are evolving. I mean, 988 was a watershed moment in July. I was just at a talk recently. They said it took 30 years for people to really understand that 911 was a 3-digit number that they could call for emergencies. Now we have the advantage of social media and modern technology to get the word out. So I think the word about 988 has already spread. But I recently I talked to somebody who's not in the business whatsoever, didn't have exposure to people with substance use disorders per se in his immediate circle. And I asked him if he'd heard of 988, and he said he had not. So it is going to take us a while to get the word out about this, and then to build that infrastructure between 988 and 911 and law enforcement and how that's all going to work together. We know that these are in a state of change, and we'll need to expand, especially for people with substance use disorders, because it's not just the same as straight mental health. When there's a substance use disorder on board, we really have to think about meeting that person where they're at and think about what are our available tools to help mitigate future risks. There's a lot of need for research to better understand best practices. And I would say that looking at the best practices with the DEI lens is going to be as important as looking, if not more important than looking just at best practices by themselves. And then really looking at what are our strategies within our community that we can use for engagement as we go forward. So with that, I think I will stop, and I will stop sharing my screen and open it up for questions.
Yeah, so if anybody has any questions, feel free to use the raise hand feature, and we can go ahead and unmute you for you to ask your question.
Or comments. I guess I would throw it back to the audience then. I always think if the audience is struggling, I'd like to throw it back to the audience and hear anybody talk about whether they're having any experiences with the crisis services, positive or negative, and then also, you know, challenges and opportunities that you're seeing for engagement. Love to hear people's perspectives from Washtenaw County.